Her work is mostly related to patients with congenital heart disease, with specific focus on risk assessment of pediatric patients undergoing non-cardiac surgeries. She has written more than 60 publications, multiple textbook chapters, and a handbook on pediatric cardiac anesthesia. In addition to her daily academic career, she is a member of the board of directors of the Congenital Cardiac Anesthesia Society, chair of the Congenital Cardiac Anesthesia Society Communication Committee, and the editor of the newsletter. And today she will speak about, and she will present to us the usefulness or not of near-infrared spectroscopy in the diagnosis and management of low cardiac output syndrome. Thank you, Viviane.
Thank you. Good evening or good afternoon, depending what area of the world you are listening to our seminar. Thank you for the European Association for inviting me. Mona and Dr. Tahan, thank you as well. I have no disclosures. And the outline of this talk will be really to review the NIRS technology, try to define any current application of NIRS in pediatric cardiac surgery, and examine if there is a role for NIRS in low cardiac output state by reviewing the current literature on the topic. So definition of low cardiac output syndrome, I think, has been well defined by Dr. Ferroni earlier in his previous talk. It is a clinical manifestation of the mismatched oxygen delivery and metabolic demand. And the timely determination is important because it will help us optimize cardiac output while managing the patients. It will optimize systemic oxygen delivery as well as tissue oxygenation, which with the hope is to lead to improved outcomes. So this study has been mentioned by most of the speakers today during the webinar, looking at what is the monitoring that people use for low cardiac output, but also what is the management. And monitoring is mostly lactate, physical exam, intermittent venous saturation. And even though some use NIRS, it is still 26%, which is less than around a quarter of the individuals who use NIRS. So even though it's only 26%, I think it is important to understand what is the NIRS technology and try to understand how would that be used in low cardiac output state. So near-infrared spectroscopy is relying on a light emitter as well as two detectors here, as you can see. And the path that is followed by this light is a banana-shaped pathway that goes one to the small detector and one to the further detector. So you can see here on this the image, this is the light emitter, this is the detector, the scalp detector and brain detector, which is the closer and then the further away. And the depth of penetrance is really half the distance between these two light detectors. And hence the depth is not really deep into the brain, it is more superficial. The NIRS, what is it actually measuring? It is measuring tissue oxygen saturation. It is a concentration of the oxyhemoglobin and the deoxyhemoglobin. It is a weighted average because that area that I just showed you in the brain would be a mixture of arterioles, venules, as well as capillaries. And the nomenclature that we use, whether it's regional saturation, tissue oxygenation, tissue oxygen index, or cerebral oxygenation saturation. So it is not a direct measure of the oxygen delivery and consumption. However, it's a surrogate of the oxygen level that is in that area. The NIRS technology is multiple. There is the continuous wave, there's the frequency domain, there's the diffuse correlation spectroscopy. However, the continuous wave, it is the technology that is mostly used, and that means it emits light at a constant intensity and measures the intensity of the light emerging from the tissues. So it's the reflectance spectroscopy. And it is relatively inexpensive, it is portable, and it is used to calculate and display real-time continuous cerebral and or somatic hemoglobin oxygen saturations. So based on oxygen supply and demand, this has been also shown in the previous talks, looking at what is it that we're actually measuring based on the oxygen supply and demand that are affected by multiple factors during management intra-op as well as post-operatively. So the NIRS modalities, multiple technologies have been developed. There's at least here 6 that I've listed on the slide that are FDA approved for use in children. And they have different proprietary algorithm and different weighted average of venous and arterial. Some use the average of 70-30, some 75-25. So it is different. However, they all come up with a number for us to use during the procedures. And so the most common use of NIRS as known is the cerebral NIRS application. It is used in pediatric cardiac surgery. It is used unilateral or bilateral. And there has been enough evidence showing that a low cerebral NIRS have been correlated with increased prevalence of radiographically neurologic injury, increased biochemical markers of brain injury, or even developmental maturity at 1-year follow-up. Preoperative cerebral NIRS value may also correlate with neurodevelopmental outcome. However, is like cerebral NIRS also used for low cardiac output state, and that we will discuss in a little bit. But this is the algorithm that we use for cerebral NIRS. If your NIRS is low, whether it's a number less than 60 or a difference between the right side and left side, or a percent decrease from the baseline, then usually what we do is looking at the patient's oxygenation, ventilation, looking at the head position, and then start to look into factors that affect our cerebral oxygen supply or demand. Now, to use NIRS as a low cardiac output measurement, looking at correlation with venous oxygen saturation, this is a study addressing 73 neonates after stage 1, and they have looked at venous oxygen measured by co-oximetry and tried to correlate that with the cerebral NIRS. And they have shown that really the sensitivity of what they mention here as regional saturation, which is the cerebral, was in the range of clinical interest in detecting a venous oxygen saturation less than 30%, extremely low. In fact, they have shown that in any time the measurement of venous oxygen saturation was less than 30, it was picked up by a cerebral NIRS in less than 1% of the cases. And similarly to less than 40, it was picked up in less than 1%. So what does that really tell us? It says that the cerebral oxygen measurement by NIRS in isolation should not be really used to detect low venous oxygen saturation less than 30, because its sensitivity is low. And the same way in this study, they have shown that the cerebral saturation of 50 or greater should not be considered reassuring, though the values below 30 are specific for low venous saturation. So can we use other measurements for NIRS to measure low cardiac output? Is it possible to use somatic NIRS, renal, flank, abdominal, liver, flanking, or muscle NIRS location? And so in normal conditions, you have the renal, which has a low extraction rate of 10 to 15%, and it is an under sympathetic control. And we have the cerebral, which is the higher oxygen extraction, around 35%. And this is under the control of pressure autoregulation or perfusion metabolism coupling. And so a ratio of the somatic cerebral or the gradient of somatic cerebral difference is around 10-15%. And a change in that gradient could be a reflection of an impaired perfusion and the determination of the low cardiac outputs. When we talk about NIRS somatic, I think in the next few slides, I want to go over which locations should we use. Is it a predictive of maybe lactate change, or is it a predictive of actual cardiac output? And this study, looking at the location, they wanted to measure when we put a NIRS onto measurement of the kidneys or abdominal, what are we actually measuring and what is the depth that is needed? As I showed you earlier, it's a very shallow reflectance between the emitter and the sensor. And so these are children 0 to 18 years. They have the kidney hairs located at T12 to L2. And the depth of sampling, as noted, is around 1 to 2 centimeters. However, in some cases, especially in older patients, where your wall thickness exceeds 1.5 centimeters, you can see here that you have any patients above 20, they have a bigger distance of 1.5. So you are at the edge or even above the distance that is allowed to actually reach the kidney. So maybe the kidney measurement using the NIRS is not accurate really in patients that are above 20, which is almost 4 or 6 years of age. So then this one looking also at renal oxygenation, and they have looked at 37 patients less